Hi, everybody. Welcome to the Data Literacy Geek Fireside chat. And today we have a special guest, one of my dear friends I have met, I think about 10 years ago already, when I was a champion at UWV. We have spoken sometimes with each other. We met in person, I think, in Orlando for the first time.
Yep.
When I was there at Connections, so when you were a clicky. David Bolton, welcome, man. Love
Thank
to have
you.
you here.
Nice to meet you, David.
Great introduction. Thank you very much.
Yeah. Could you please introduce yourself to our audience and the attendees of our Data Literacy Geek platform?
Sure. So my background has been with Click for many years. I was with Click for 11 years, started in 2008. And I ended up running the industry solutions and value engineering team at Click. And I left the business in February this year and have recently joined a company called Draper and Dash. So Draper and Dash were a Click partner for many years, so I've worked with the guys for a long time. And their focus is entirely on healthcare and transforming healthcare through data. So a lot of the work I was doing previously had a huge bearing on my passion for using data in healthcare and really supporting patient outcomes. And the guys at Draper and Dash have some fantastic tools to do that. We've recently launched a data science platform that's all about driving the use of data science and advanced analytics in analytic programs. And we do a lot of work with health systems, mostly across the UK, but also Middle East, Australia, US, all across the world. So I'm delighted to be here in the role of Chief Revenue Officer. So I'm kind of responsible for our go-to-market and how we engage with our customers and sell our solutions, and it's a new chapter in my career. So yeah, it's great to be here.
And could you please give us a good definition about your role as a chief return or investment
revenue officer?
Revenue officer.
Yeah, I mean, it's effectively head of sales. So I'm responsible for all the sales part of the organisation, but I also work really closely with our product team around how we define and message all of the customer value that we can deliver with products. So it's around kind of messaging, positioning, working with customers to support their use cases around the solutions, and working with our marketing organization around how we take that message out to market and generate what should be a lot of excitement about what we can do for the healthcare industry.
Yeah, well, as you know, it's my sweet spot as well, huh, the healthcare. Yeah. Unfortunately, I'm not that much anymore into the healthcare part. I hope within 7-8 months I could join that fantastic team again. Data literacy in healthcare. How do you see that? Because I think there is, from my personal perspective, I think there is a big gap in data literacy skills. If you look at the data literacy for healthcare, especially.
Yeah, no, I think that's true. It's I think the gap is closing. I think we're starting to see a lot more work in data literacy in healthcare and really trying to drive the value case for data and insights, especially down into the front line of the organizations. So, 10, 12 years ago when I started working with data in healthcare, I think there was a general recognition within the kind of executive level management tier that data was a tremendously valuable asset for monitoring and managing performance. So volume of patients, where the gaps were, where the challenges might have been financially. And that all came from the original kind of reporting world, trying to generate reams of paperwork, and a board report was often this thick, and it was a real challenge. So I think moving from that into more self-service analytics, driving kind of dashboard type views where people could self-serve and ask questions of, I think that started the data literacy journey. And for a lot of clinicians who previously maybe had been told information but not really had access to ask questions, that was the start of that journey into really understanding what the data could potentially do for them as frontline workers. And then more recently, I think we're on this kind of shift at the moment where people in healthcare especially spent a lot of time looking at what had happened. So there was an awful lot of kind of descriptive analytics. How many patients did we treat in this condition? How many people arrived at the ED on this day at this time? Which patients are on certain drugs or drug regimes? So that kind of information has always been available and reported on and then available in dashboards. And then we saw the shift towards more diagnostics. So looking at why those things happen. So if there was a delay in treatment times in the ED on a certain day, why was that? And how can we use data to explain the discrepancy? And often it might be, there were a number of staff, off sick that day, and that caused waiting times to increase, or maybe one of the operating theatres was shut down because of a technical problem. It's connecting the data together that drove that kind of descriptive nature. And I think that in its own right has driven data literacy, because people have seen that by understanding and working with and analysing the data, they're able to get really valuable information to try and prevent things happening in the future. And I think what we're working all towards now across healthcare is that next step, which is the predictive side. So how do we use all of the historical data to give us really accurate information on what's likely to happen? Because when we get that, we can start to make really impactful decisions about where we invest in resources, how we manage patients with certain conditions, which patients need to be monitored more closely when they're discharged from hospital. And that's really that next step. And I think that's going to highlight the need for data literacy even more, because the opportunity to do amazing things with it is even bigger than it was when we were looking at that descriptive and diagnostic piece back in the sort of mid-2000s.
David, what would you say is the greatest kind of benefit that frontline workers are deriving from data today?
So I think often it comes down to variation. So that's a strange statement, but if you think about a group of clinicians working in a hospital, let's take orthopedics as an example. One of the most common kind of elective conditions or elective procedures is kind of knee replacement or hip replacement. If you look at 10 surgeons that carry out a knee replacement procedure, I can guarantee there'll be significant variation in how they carry out that care. Now, the procedure itself will be very similar. It's the same process to go through, but pre-operative, post-operative, even looking at things like physiotherapy, how long they stay in the hospital for, which drugs they're given, those things vary in it. And typically, although there are standard pathways, clinicians have their own preferred mechanism for doing things. So what the data is doing on the front end there is actually showing them which of those things is actually worthwhile, which is good and improves outcomes, and which has no impact on outcomes. So it's directly changing behaviour. And I worked on a program a long time ago with a hospital in Sweden where they did exactly that for knee replacements. And by breaking down the care into segments, they were able to see that one ward had a much lower length of stay and a much higher success rate. And they looked at all of the stages of care, and bizarrely, the thing that actually stood out was when patients come out of the operating room, on one ward, they were letting them basically rest overnight, and then they started to manipulate the joint and get the patient working with the new prosthetic. On the other side, as soon as they were out of recovery, they did the manipulation and the physiotherapy. That difference was clinically led, but it led to an extra day of length of stay in hospital. So they used a bed for a day longer, and it meant that they were more likely to come back into the hospital with post-operative pain, challenges, things that needed to be addressed. Now, they had no clue between the two departments that they were doing anything differently, but the data shone the spotlight on that change, and that enabled them to change the behaviour across the board, which saved them hundreds of bed nights, massive amounts of cost, and enabled them to get more patients through and have the treatment, so reducing the waiting times. So that's just a really simple example, but it's often the things that we don't know that the data highlights, right? It's kind of, I don't know what to look for because I don't know where the variation is. But when you see it in a visual format, things stand out. You get a spotlight here, you get a chart there. And that's where I think clinical data literacy can have a huge impact.
All right.
Because they're able to see it.
And how was the adoption within these wards, right? So were people like eager to jump on this new idea and doing things differently?
Yeah.
Or?
That's a really good question. and I can see that's born out of experience, because adoption is always a challenge, right? So we found that if you engage clinical teams throughout the process, all the way from the very beginning, okay, what are we trying to do? What's going to impact or help your job? And what's going to impact or help patients? If you get them engaged right at the beginning to answer those questions and start to build a plan, then the adoption is really good. If you build a solution in a silo, you work with the informatics team, for example, you build something you know is going to have a clinical impact, and then you deliver it and say use it, it never works.
There you go. Nope.
Yeah. So the key all the way along is to get early engagement as broadly as possible with the user base, whether that's in a hospital or a business or a government organization. It's the same in every single place. Early and regular engagement.
Yeah, and what would you say is the golden formula to get this early engagement within people?
Yeah, that's a really tricky one. I don't know if there is a kind of magic bullet for that. I think there's two ways of looking at it. I remember working with a health system in Australia a few years ago, and the CEO of the hospital had done amazing things with data, and I asked her the same question. I said, what was the magic bullet? And her answer was, I used a carrot, not a stick. Okay, and the kind of explanation of that was she's seen data programs where the drive, the outcome, the perceived success of the program is either cost cutting or kind of resource cutting. Whereas her outcome, her perceived success with the clinicians she worked with was all about patient outcome. And because people become doctors to provide care, right? They want patients they want to make them better. They want to give them a higher quality of life. So if you go with that approach of patient outcomes first, cost savings second, it's much easier to get clinical engagement. Now, obviously, you can't necessarily take that model and use it in other industries because that's very specific to healthcare. But I have seen similar things in government. So I did a lot of work with the public sector. And I think anything where your customer value is the initial focus really helps to get the engagement, because people want to make customers happy, whether they're patients, citizens, customers that are buying a product or using a service. I think focusing on customer value is really key to get that early engagement with teams.
So it's driving value through empathy, if you want.
Absolutely.
All right,
yeah.
Brilliant. So Angelica, I just cut you off earlier, so we wanted to ask a question.
Actually, what I would like to know, if you look at healthcare and the primary use cases, what kind of use cases do you see, David?
So, I mean, there's all the traditional ones. So looking at inpatients, outpatients, emergency room, operating room utilization, they're the most common ones we see. But I mean, loosely, you can kind of break them into three areas. You've got clinical use cases, operational, and financial. And that's, I guess you could say, is similar in every industry. You normally have operational, financial, and kind of sales, marketing type thing. In healthcare, it's normally around clinical. And in clinical, the most common use cases we see are around clinical variation. I've already talked about that. Things like medicines optimization. So which drug regimes work, which don't. Can they be delivered in a more effective, cost-effective way, or better patient outcomes? Or maybe switching from branded to generic drugs, which is still a problem in the NHS. There's a lot of people prescribing branded, which the generic version's available. And then on the operational side, it's things like how do we maximize the efficiency of our services? So it could be looking at workforce. We've done a lot of work recently with a hospital looking at their workforce and trying to manage the demand and capacity that's been caused by the COVID pandemic. So there's a big challenge in healthcare now, right? I mean, throughout the summer period, or even spring, summer, when the pandemic was at its height, a lot of elective care was put on hold. So a lot of people waiting for kind of planned procedures, they were put on hold because the hospitals quite rightly were trying to maintain capacity in case of COVID demand. Now that's kind of dropping down. Okay, we're kind of moving into a second wave a little bit from a case point of view, but from a hospital perspective, we're now in a position where we've got thousands of patients that have been waiting a really long time for their elective care, for their planned care. So the challenge that presents is kind of twofold. How do we get the capacity in the hospital to deliver it? And how do we get the capacity in our staffing and our workforce to be able to manage it? Right? And they're two very different things. One's about beds and rooms and theatres. The other is about surgeons and nurses and physiotherapists. So we've been working with them to build out some predictive modelling. If we were to do this, what impact would that have here? If we lose 8% of staff because they're shielding from COVID because of maybe something in their family or a condition, what impact will that have on our ability to meet demand with capacity? So that's quite a common one. So operationally, a lot around that, and then financial speaks for itself. You know, how do we balance the books? Basically, we're either getting paid by results, where we're on a tariff, we get paid per procedure, or we're paid a block contract where we're given a set amount of money for a set population. But equally, it doesn't matter. You have to balance the books. So how can we use data to show us where financially we can optimize the model to manage the excess in demand versus capacity, the challenge with staffing and the need to use more bank and agency staff, which are more expensive. You know, maybe the need to use or to shift patients with certain conditions to other hospitals because they have capacity and we don't. So there's a ton of work that's needed and is going on right now to look at demand and capacity, workforce modeling. You know, even
we have the same thing here now with the distribution of patients all around the Netherlands, because hospitals are full with COVID patients, and of course you have now they divided the healthcare system in hospitals in two parts: the dirty one and the clean one. And people are being transported to other hospitals because the hospitals in Amsterdam or in The Hague are full. So, and they have this, unfortunately, the COVID pandemic, it's terrible. My own daughter is getting tested tomorrow because she has a fever and no taste. So I think we almost definitely it will be COVID. This pandemic forced the healthcare to work together in having a overview from nationwide. A nationwide overview of beds in hospitals to admit those patients with COVID, and also
absolutely.
I think that's I think what is happening everywhere, but also gaining speed in some processes, like the ones we discussed many times, call to balloon and call to needle, where time is of the most great essence to help a patient.
Absolutely.
And
no, I agree.
And if you calculate further, and that's actually what you're saying, if you calculate further, if the quicker you help a patient, the less time he needs probably in rehab. So that saves money, but also less stay in a hospital. So the business case is actually there, but in healthcare, unfortunately, we don't work with use case or with business cases, but these are the concepts I was thinking about. We discussed about it a lot.
No, I agree. It's a massive challenge, I think, for every health system. And the fundamental truth is there's going to be an awful lot of people waiting a lot longer than they planned for care because the capacity's been taken by COVID. Obviously, the number of staff is lower, the risk is higher. There's a lot of challenges which need to be addressed. I think looking at it at a system level is probably the only way we're going to manage this, whether it's in the UK with the NHS or in the Netherlands. You know, rather than looking at necessarily where somebody lives, it's looking at matching capacity to demand and potentially having to move people around a bit more in order to address that. But I think people have, they have kind of, they have found new ways of working. So I've been on a number of customer sessions recently where people have been sharing best practice. How have you coped with these challenges? Whether it's in children's hospitals, trying to get children in for care and how they manage the testing process, the communication. We've gone from, 90-something% of GP meetings being face-to-face to 90% being done remotely, either on a webinar like conference call like this, or through the phone, or and that was always going to happen, but I think it's been accelerated by COVID. And actually, there's a lot to be said for that being a positive thing. I think, people's need for medical care is never going to change. It's one of life's, absolute guarantees. There'll always be a need for medical care. But being able to deliver that care more efficiently, more quickly, and more securely from a viral perspective was always going to be a need that we were addressing over the next 10 years, but we've kind of forced it to happen in a few months. So there is some positive things that have come out of this. And, GPs I've spoken to have said, as much as they miss the patient face-to-face interaction, they are able to deliver a lot more care to a lot more people because there's less waiting. They're going directly from one to the next, They don't get necessarily the same diagnostic information. But for people who perhaps have, you know, the other thing that a lot of people are talking about now is the mental health impact of COVID. You know, a lot of people that are perhaps living alone and very isolated, or you know, suffer from anxiety, stress, exhaustion, trying to keep the job going, keep the lights on during this pandemic. There's a big challenge around how do we manage mental health care more effectively. And the kind of face-to-face, you know, off-site calls and the ability to run things through mobile devices, that's a great help, because it can be delivered more quickly and much more efficiently than the capacity would necessarily dictate. So I think there have been some positive outcomes from this, and a lot of them are being driven by data. And it goes back to a good friend of mine I used to work with called Jordan Morrow. I think you know Jordan. He's the data literacy lead at Click. So he defines data literacy. We've probably all heard it 1,000 times, but the last point of his definition is to argue with data. And what he means by that is use the data to make a good argument. Right? He doesn't mean argue that the data is incorrect. He means use it to make a good argument. And I think what COVID has done is allowed us to actually use the data in a way that hasn't been used before. You know, actually take the information that's coming through and use it to argue a point of view on how we deliver care, how we plan, you know, outpatient appointments, how we match capacity to demand. Because previously a lot of it's been gut feel and kind of finger in the air, you know, I think we need to do this. But the data is now being seen as absolutely critical to that process. And that's a core tenet of data literacy.
Yeah, from that perspective, I think so too. If a GP, you know, as you know, I have been working with the GPs a lot as well, and we made some beautiful reports. But you know, if you have the diagnosis and if you see what kind of treatments are given and what the results were and the days of admitting in the hospital or on the ICU or whatever, you know, these things can bring valuable insights and help healthcare organizations to make good decisions. So yes, and that's where data literacy for healthcare comes in. They have to dare to grab that data and make some good insights and argue with those insights, because discuss them, like the example, of course, for the cold to balloon and cold to needle, discuss the exceptions and improve from the exceptions. So yeah, and that's cool.
I agree.
So
it's exciting times.
Yeah, it definitely is. And the what you've just said now is that kind of like this pandemic situation has fast-tracked loads of developments around like the technologization sorry of the healthcare sector and the way that like data is perceived in hospitals. Do you feel that this also like trickles down to people like on the very front line? So do you have somebody with instead of with a clipboard standing there with a tablet now assigning beds to patients, or is that what you're seeing these days?
Yeah, I think it varies by setting, you know, so, you know, frontline impact, I would suggest that the acceleration of technology has probably moved on 5 years in 6 months. I think it's as big as that. And from a frontline point of view, GPs, family doctors, I think they've probably been the ones to change the most quickly, because they've had to still see patients. So they've had to use technologies for video appointments, for, you know, online appointments and phone appointments, and convert 90% of what they do onto that format. They've done that almost overnight. So that's amazing. I think frontline in hospitals, there's probably, you know, a lot of the battle on the front line around COVID wards and actually, you know, maintaining patients' quality of life and healthcare with COVID is probably not so data related. It's more about clinical effectiveness, policy, procedure, process, you know, all the things that they have to think about in those situations. So I think a lot of the focus has been on, you know, maintaining the safety of staff, because that's a big challenge for them. There has been a large number of staff that have suffered tremendously by getting high viral loads in hospitals. But the data that's supporting that around, you know, what do we expect the volume to be in the next week and the next month, and helping the hospital to prepare their capacity to deal with that, I think that has had a direct impact on the front line. But it's not necessarily something they use themselves on a tablet.
All right. So one question is like, so you're creating or you're working on or you're having a data science platform for the healthcare services,
Yeah.
right? So this means that you're directly involved in these predictions and these predictive models. Could you elaborate on what that platform does a little bit?
Sure. So the data science platform is a collection of data science models specifically for healthcare. So we've worked with customers around the world building predictive and machine learning models around specific use cases. So it could be predicting a patient's likelihood of being readmitted post-surgery. It could be the volume of patients arriving at ED, theatre utilisation or operating room utilisation, COVID R0 number. You know, that's a big one at the moment, is tracking that and trying to predict it. All the way through to patients that are maybe stranded for a long period of time in hospital, they've got a long length of stay. There's about 15 or so core models which basically act like a data scientist in a box.
Mm-hmm.
So the idea is that a health system, and the majority now have a fairly good data landscape. They've got systems, they feed it into maybe a warehouse, and they feed it out into their analytics, whether it's reports or dashboards or whatever. So the data science platform sits alongside the warehouse and it collects data. So we have a data dictionary for each model. We say what fields are needed, what format they've got to be in. We then have an ETL that pulls the data out, runs the model, trains, tests and deploys it, schedules it on a daily basis or hourly, feeds the data back out so they can embed that into their analytics. So the whole concept here is that it's specific models for healthcare that can be plugged in a matter of days. And it shortcuts the development of a model, the skills required to use things like R or Python, the integration piece with the front end, and gives tried and tested models that can drive real value really quickly.
All right, that sounds really great. What would you say is the most impressive use case that you've been able to or currently designing in conjunction with this?
Yeah, I think we're doing some work at the moment with a fairly large hospital group around demand and capacity planning. So I've talked a lot about that, but what we've done with our DSP, with the data science platform, is we've used around 7 or 8 of the core models, and we're feeding all of them out into a single analytics layer that then allows them to look at demand and capacity across multiple departments, specialties, the financial impact, the patient volume impact, the COVID impact, and see that in a single holistic view. That to me is really impressive. And we did a launch of the platform last week, and we showcased that as an example of what you can do with it. And it really is a kind of hospital view in a box, looking at now and the future. I think it's superb.
That's really cool.
I was already enthusiastic, and now I am even more.
Excellent.
All right, so this integrates like the current descriptive part with the prescriptive part. So what are people gaining from it? And except for so they're getting like the entire perspective for demand in the future. So what I don't have like a healthcare background like both.
Yeah. So what's the value of that?
Exactly. Yeah.
Okay. So really simple example. Let's say that the model predicts that we're going to get a high volume of patients arriving at the emergency department on a given day. Could even be in a given time slot. So maybe between 7 p.m. and midnight, we're likely to get a large volume of patients. And we know from the data historically the types of patients we're going to be seeing on that day. So what we can then do is match our resourcing, our staffing, and our availability on the ward to the data that's being predicted. So rather than having a huge influx of people in that time period, having not enough people to treat them, we can adjust the staff and roster base so that we have less staff in the quiet time and more staff in the busy time. Now that kind of happens already, but when you can be more precise, you can then drive the performance in terms of waiting times and admission times, get everything right because the data is giving you a really good steer on it. That's cool. The other really good example there might be readmission. So if a patient comes in for a particular treatment, based on all the data we know about the patient, we can probably, within about an 80% accuracy, predict the likelihood of them having to come back to hospital. And we want to avoid readmission at all costs. That's not what we want. We want patients to be treated and then recuperate in the community. So if we highlight a patient whose likelihood of readmitting is high because of all the factors we know about, then the clinicians can intervene directly with that one patient, do what they need to do to reduce that chance, and then get them out and back into the community. They're just a couple of really simple examples of how predictive analytics can actually drive outcomes for patients.
That's really cool. So do you use like machine learning and data science to support diagnostics as well, or?
No, not at this stage. Most of the work we've done around ML and AI is all about operational, clinical, financial kind of performance tracking, and being able to predict likelihood of things happening, maybe looking at, so the machine learning side works well with the readmission predictor. But no, from a diagnostic point of view, I've seen some phenomenal work in AI programs looking at things like scans, cancer scans, eye scans, so they're trying to detect abnormalities in the retina.
One of my projects, huh?
Yeah, incredible. I mean, phenomenal stuff. And that's not an area we're working in. We're looking at kind of big data coming out of health systems and trying to figure out what value add can we give with data science in a really quick and simple way. That's what we're trying to do, is take what is a very complex thing and make it really simple and easy.
So you're looking more on the like operational side of workings with. So it's still patient focused with regards to patient care, especially
Absolutely.
the readmission.
It's a combination of clinical, financial, and operational.
Exactly, but there's not the medicinal part currently.
Not the diagnostic part. We do look at medicines, and we have a machine learning algorithm to create medicines optimizations.
Awesome.
So how do you optimize the way medicines are being prescribed? But not on the diagnostic piece at the moment. That's more in the realm of kind of AI and trying to figure out certain patterns in images. So we haven't yet got into that.
All right. No, that sounds absolutely great.
Cool.
Yeah, I did that. I did a prediction project with my team about how many patients would likely come to the emergency post in the coming month, in the coming quarter, in the coming years, to not only predict on staffing and how you could arrange a good staffing setting, but also allocating budgets, for example. So that was actually necessary to do, but that's a fun project. That's fun because it delivers immediately value. It delivers value.
To integrate the playing schedule of Ajax Amsterdam as well.
Yes, I did. Yeah.
That's cool. Yeah, this is what I love. So with that, so I'm sorry, I'm really writing this machine learning platform, but I think it's really interesting. Do you do you integrate like the data from the hospital and all of the like patient related information?
Yeah. So I mean,
do you have external data sources as well?
Well, it could be both, actually. So in most cases, it's internal data that's being recorded in systems held on site. But there are some elements where external data can be really valuable. So I've seen programs where data from things like weather services, that's a big one for the emergency room. If you get temperature drops for a consistent period of time, you're more likely to get trips and slips and people breaking wrists and arms and car accidents, things like that. So you can start to do predictions based on weather patterns for emergency medicine. Things like using external data on the prevalence of certain viruses. So the flu virus, for example, if you see patterns of flu virus being detected, you often get a hospital visits after that as well. So it could be external. The majority of the models we run are internal data, but you can use both. Yeah, I mean, as you know, with platforms like Click and others, you can pull data in from any source and drive that forward.
Population growth, you can add everything. Population growth, weather predictions, what we did with the project. Yes, socially, we did a project with the people were saying, okay, when there is ice on the road and there is snow, we will have more patients in the ER or in the emergency care. And we found out that it's not that the number of patients is growing, but that the diagnosis is changing.
Yeah.
From colds and stomach ache to broken wrists and swollen ankles and all this kind of thing. So that's where the things that you could find out. So that's actually very neat to do. So we have to
need,
discuss more again.
Yeah, and you need more time in the radiology department. You need more people doing X-rays and reading diagnostics. So it all kind of flows into resource and how you allocate it. But yeah, it's a fascinating field. I mean, I think it's amazing what you can do with data and the impact it can have on healthcare, both operationally but also clinically.
Yeah.
And it's an area that I'm very passionate about. You can tell.
Yeah, we know.
All right. So
that's cool.
Cycling back to like data literacy. I mean, we could probably talk about like data integration and data science for hours. Obviously, like data science to like the uninducted, and to me most of the time as well, feels a bit like a black box approach. Do you feel that this is sometimes a problem to get people to
engage with it?
Exactly.
Yeah. I think for me, and I've been this way since I began my data career. I think the key is always the outcome. It's always the use case and the outcome. You need to be able to tell a story, right? If you talk to somebody about a data science model and you're using phrases like gradient clustered trees and complex statistical analysis, there's no, you can see the lights go off and the switch going, really? But if you say, I'm going to build you something that helps you predict when a patient's going to readmit, and I'm going to notify you before they get discharged so you can do something about it, that's a real outcome. And then you say, well, what does that mean to the trust? Well, if we can cut readmission by 20%, what's the impact of that? Well, actually, we'll have another 300 bed nights a year available to do other care, or we'll save roughly £3.5 million, let's say, as an example. So you have to turn the data science into real world meaning. And that's all about telling stories, understanding the value, and empathizing with the use case of the individual. And if you can do that, I think data science becomes relevant to everybody.
Yeah, I think this is cycling back to empathy being the key component of the entire story again, right?
It is.
All right. Cool. Well.
Cool, huh? So I think we have to wrap up because we are already talking about 40 minutes and we could go on forever without any problem. David and I will never stop discussing data and healthcare and what we could do, and you crazy about Boris, about data science and everything what belongs there. Maybe you follow up in a year or so to see where you are heading with your team, David, and let's stay in touch anyway. Yeah, we have to. And thank you so much for joining us in our data literacy fireside chat.
Thank you very much for the invitation. I really appreciate the opportunity. And it's always great to talk about data and healthcare, so I really appreciate it. Thank you.
Thanks for coming, David. It's really great meeting you.
Cool. Cheers. Yeah. Thanks, guys.
Take care, everyone.
And have a great evening. Bye-bye.
Bye.
Cheers. Bye-bye. Bye-bye.